This is Dr. Sargisian, and I will talk about inflammation and infection today. When we're talking about inflammation and infection, we need to mention that immune response and inflammation are part of defense mechanism created to protect the body against the foreign invaders. So there are three types of protective barriers or lines of defense. First of all, it's physical and surface barriers, which can be intact skin, for example, is the first line of defense. So skin by itself is a physical barrier, and at the same time skin surface is acidic, so which make it antimicrobial barrier against infection. But this doesn't happen all the time, and sometimes of course you will have skin infection. But if everything functions well, skin will be an efficient barrier against infection. So there are thousands of microorganisms on the skin surface, and some sources are citing that it's more than 100 trillion microorganisms on one person carried. However, we have to account that this is a normal bacterial flora on the skin that will prevent opportunistic infections by other bacteria. So on the other hand, skin has sebaceous glands and also secretion of sweat, and that altogether it creates acidic environment and antibacterial enzymes. On another physical barrier is mucous membranes, which also serve to trap invaders and destroy it. So besides the physical barriers, we have inflammation and immune response. Of course, inflammation is a non-specific response. When physical barrier is broken, somehow scratch, stab knife wound, or a simple splinter, the bacteria or other microorganisms may penetrate the tissues, and this will trigger inflammatory response. So this begins with a vascular response within very short time, within seconds after the physical barrier is broken. And this is an unspecific process, and it follows exactly the same pattern regardless of what happened. That's why I listed several sources that can break the skin barrier, but however, it doesn't matter what breaks that barrier. Is it a knife or a splinter or even a burn? It's still the same inflammatory response happens. Immune response is a specific response. It's the third line of defense, some say. Every cell have proteins that we can call antigens on the surface that can identify the cell. So by every cell, I mean every cell known to us, and either it's human cell or bacteria, but everything has an antigen. Antigen is like a travel passport for this cell. So when immune response happens, the body, the immune system may identify the invader by the antigen, and at the same time lymphocytes may produce antibodies. Antibodies would link with the antigen somehow and either kill the invading cell or disable it. So the immune system has ability to remember the invader and produce the antibodies. let's talk about inflammation. And inflammation is a non-specific response, and by non-specific we mean that it really doesn't distinguish what type of invader attacking the body, and it's usually a reaction to distortion in tissue integrity or disruption in tissue integrity, trauma, some kind of injury, burn. So it works well, however there is one limiting factor in here. So inflammation will not occur if there is no blood supply, because blood supply creates the vascular and cellular component of the inflammation. So we can't have inflammation in necrotic tissue, and but if we have, let's say, decubitus ulcer, we may see the inflammatory response around the borders of the ulcer. So this phenomenon can be used widely in different aspects of medicine, but I want to mention as a trivia fact that we can use this as a tool in forensic medicine. If there is inflammation in a tissue, that means that the injury occurred when the individual being alive. Let's say if you are, if it's a staged homicide, some kind of, and if the injury occurred when the person was already dead, there will be no evidence of inflammation. I'm saying this to highlight that important factor, that there should be a blood supply for the inflammatory response, and this is one of the key points of inflammation. So that's why I'm bringing the forensic medicine example. So inflammation benefits as a second line of defense. However, not all inflammation is good, as we all know, and it may be harmful to the individual, to the patient, and destructive to the tissues. And of course we'll know the hypersensitivity reaction and different types of it, which we talked about, and the severe inflammation can be even deadly if we're talking about type 1 and anaphylactic shock reactions. So inflammation by itself, it's some kind of blind mechanism which is non-specific, and non-specificity of this makes it sometimes harmful or even deadly for your patient. So what happens when inflammation occurs? There are several signs and symptoms: redness, heat, edema, and pain. So redness, heat, edema, and pain. You can use Latin equivalents, which will be heat will be calor, edema tumor, pain is dolor, and redness, of course, is rubor. And these are the signs of inflammation that can be obviously visible and also reported by the patient. So, types of inflammation: acute and chronic, easily to distinguish. Acute, usually if you work in acute setting, you know what's this, it lasts in less than 10 days, and this is a very relative term. We can say that if inflammation lasts 11 days, it's still acute, but that's 2 weeks, it's usually the cutoff point, and if the inflammation would last more than 2 weeks, that inflammation will be considered chronic. So what happens when actual inflammation occurs? And when we're talking about it, we know basophils and we know mast cells, And mast cells also called another old-fashioned name histocytes, because as you know it's related to histamine. So mast cells, I love them so much and talk about it all the time because these are very important for the primary care or care of your patient with inflammatory response. So when injury is detected that triggers an inflammatory response, mast cells may release histamine. So histamine will cause dilation, vasodilation in local capillaries. So, okay, when we have dilation, it will increase the blood flow to the area, and it will cause basically rubor or erythema and also heat in the area. When this happens, dilation also works with bringing neutrophils into the area, and neutrophils line the endothelium of your vessels, and they would wait for the opportunity to move inside of the tissue. So when this happens, the neutrophil influx is very relatively short-term process. You cannot catch it in your lab work if you basically you cannot catch it if you are not doing interval blood draws. By interval blood draws, I mean I'm talking about blood draws every few hours. If you ordered blood draw in 7 a.m. and your next blood draw next morning 7 a.m., your neutrophil influx may occur between the two blood draws, and you would not notice the increase in white blood cells in general and neutrophils in particular. So what happens, this is a very short term process, and it will be usually subsiding within 24 hours when the neutrophils will move into the tissues. So when your capillaries dilate because of the histamine and other substances, vascular permeability will increase. So what's the permeability? It's when your capillaries leak, and the endothelium cells in endothelium are basically stretched. So what happens at this point, the exudates occur. So blood start producing exudates, and well, this is not the right way to say blood producing exudate, but the fluid from the blood leaks into the tissue. The leakage of this, of course, causes the edema, which is one of the signs of inflammation, as we talked. As this increases, the pressure build-up causes pain. So again, we got all our four signs of inflammation, as well as swelling will prevent functioning of that organ, especially if it's an extremity, that's a sprain or strain. Your patient will not be able to move it because of the inflammation and associated pain. So again, vascular permeability helped your neutrophils to run into the tissues, and think about it, when neutrophils are squeezing into epithelial cells, between the epithelial cells, and this is an interesting process called diapedesis, and it's very effective process that, as I said, takes place very rapidly, and millions of neutrophils will invade the area within few hours. So you already heard this expression before, I'm sure, but I will repeat it again myself, that neutrophils are the first battalion of soldiers that attacks in the inflammatory process. And by soldiers we mean, of course, the cells. They will arrive first, and we have lots and lots of them. They are attracted to injured area by chemotaxis, of course, by process of chemotaxis. So chemoreceptors that located on neutrophils, they will detect the source of release of chemically active substances and will make neutrophils to move towards the site of the injury. So when neutrophils will arrive to the scene of the injury, it will be the beginning of phagocytosis, and phagocytosis, of course, it's the eating process by the cells. So they will start destroying the foreign materials and dead cells, and again, please remember that neutrophils unfortunately don't live long, so they would start dying, and they will be producing the purulent exudate, so basically the pussy exudate. Another type of exudate is fibrinous exudate, which is a larger injury with severe inflammation. So fibrinous exudate, it's composed of fluids and large amount of fibrinogen. So when we're comparing to serous exudate, the leakage of fibrinogen will signify more severe inflammation. So fibrinogen is observed, or presence of fibrinogen observed, that we're looking at a process like a streptococcal laryngopharyngitis or pneumonia of bacterial origin. In these cases, the lesion will be actually having mesh-like structure. So when we're talking about superficial wound with this, the wound may be covered with dried fibrinogen exudate, which of course we all know that it's a scab. Purulent exudate is pus. Again, it's collection of dead neutrophils. So approximately 3 to 4 days after inflammatory process begin, the other type of cells will arrive to the scene, which are the monocytes. So monocytes will leave the bloodstream and move into the tissue and become phagocytic cells, and then will turn into macrophage. Basically, it's the same cell, but it's just changing the name, because from blood it moves into the tissue. So, but neutrophils still may be, dead neutrophils still may be present at the location of the injury, and may create an abscess, which is a collection of pus, of course, and which, as we know, needs to be drained and emptied, because the abscess may be causing significant pain and also can trigger further inflammation and infection. Empyema is accumulation of free pus in a body cavity, and again it consists of dead neutrophils. So what type of inflammatory lesions in general we can see? We talked about abscesses. Ulcers can happen secondary to inflammation. An ulcer is the absence of the tissue. So it's a result of the injury and the inflammatory response that followed the injury. So what's the ulcer is? It's the result of necrotic tissue slogging off and leaving a crater or excavated area. The best example probably of ulcers is the stomach or duodenum, your gastric or duodenal ulcers or peptic ulcer disease. The other example, your decubitus ulcers you see in long-term care facilities, and which is a different origin. But both of the types are still ulcers. It's slogging of the necrotic tissue and creation of some type of crater or indentation. Cellulitis is a diffuse and widespread acute inflammation, and it can be seen in tissue, and tissues like on the surface, in the skin, and subcutaneous tissue. Cellulitis caused most of the time of streptococcus, of staphylococcus bacteria, and it's really some type of failure of immune system when really the opportunistic infection takes over and the immune system fails to protect the surface pathogen. And cellulitis can of course be very dangerous and spreading, but on the other hand, if antibiotic treatment introduced, PO or intravenously in severe cases, it's usually treated effectively.